Welcome to today's webinar. My name is Russ Rowan. I'm the Director of Marketing here at Osteogenics. Before we get started, let me address how we'll be interacting today. From a technical perspective, we can't hear or see you, but we'd love to answer any questions you may have. We will reserve the last 10 minutes of our time together for question and answer. There's a Q&A button on the right-hand side of your screen where you can type your questions at any time. We'll try to get them answered after the presentation. Once the webinar is completed, you will receive a feedback survey in your email. Please complete the survey, and once it's completed, you will receive your CE certificate. Now let me introduce our presenter tonight, Dr. Sean Rotenberg. Dr. Rotenberg received his dental degree from the Medical College of Georgia and achieved his certificate in periodontics and a master's in science degree from Ohio State University, where he served as chief resident. Dr. Rotenberg is an assistant professor for the Division of Periodontology at the Ohio State University College of Dentistry in Columbus, Ohio. He also maintains a private practice in Columbus area where he focuses on periodontal therapy, implant therapy, and periodontal plastic surgery. We're fortunate to have Dr. Rotenberg with us tonight. We appreciate him taking the time. We appreciate everybody on the call taking the time to spend together tonight. With that, Dr. Rotenberg, I'll turn it over to you.
Thanks, Russ. I appreciate the opportunity to come speak on a Tuesday night. It's Tuesday. It's the summer. It's 8 o'clock on the East Coast. It's earlier everywhere else, but so I'm going to try to make this as entertaining as I can tonight. Lots of pictures, lots of surgical photos, very little words, but we're gonna have a great time tonight. So if anyone's seen me talk about MicroDerm in the past, we're going to be discussing about techniques. We're going to be discussing, why it's a new material, but we're also going to kind of show longer term results. The title of this presentation tonight is it's my 18-month relationship with a microsurfaced acellular dermal matrix. Are we officially a couple? Because really, when you're using a new material, it's kind of like dating, right? At first, you're new to it. You don't know what to do as much. You've kind of read about the material, maybe talked to some friends about the material, but you really haven't had the experience yourself. And as we all know as clinicians, to really master the use of material, it takes time, it takes practice, and you can't just be a serial dater of materials. We all know if you try a new material every week, it's never going to pan out right. Being a materials floozy doesn't equal becoming a good surgeon. You really have to get involved with the material and find out what its strengths are, and that's how you have this great, long-lasting relationship. So I'm gonna show my relationship with MicroDerm over the past 18 months. Is it love-hate? Do we love each other? Well, let's find out. We're going to go from there. So, disclosures. Yeah, I teach at Ohio State. I have a private practice where I work most of the time. I teach at Nationwide Children's. Osteogenics pays me to do some talking once in a while. But that's really about it. I'm not on their board or anything like that. I enjoy being given the opportunity to speak. So those are my disclosures there. But let's get right into it. So soft tissue augmentation. We're going to go quickly through, what the standard of care is these days. We all know the standard of care for soft tissue augmentation is the subepithelial connective tissue graft. There have been systematic reviews, and study after study after study has shown that autogenous tissue, the subepithelial connective tissue graft, is the gold standard when it comes to root coverage, gains in keratinized tissue, and longevity. And today's presentation is not refuting that. When I see patients and I discuss their options, I always tell them, listen, your tissue is the best option. There are alternatives, and they have their pros and their cons, and there's reasons why we want to use alternatives sometimes. But at the end of the day, autogenous soft tissue is the best. But the downside of autogenous soft tissue is, as we all know, we have to go somewhere in the mouth to get it. Typically, that's the palate Either we can go to the tuberosity, we can go to the premolar area, but if we're doing a free gingival graft or even a subepithelial connective tissue graft, it means that we're harvesting tissue from the palate. So what are our other options? What if patients don't want to use their own tissue? Well, back in 1998, Dr. Harris decided to try to use allograft soft tissue, just like they're using in medicine for burn victims, to use it for soft tissue augmentation for root coverage procedures. And lo and behold, he found out that an acellular dermal matrix could be used as an alternative to an autogenous graft. This material, it was devoid of cells, and really it just acts as a matrix. There's nothing in there that a patient's going to reject, but by processing it, you get rid of all the cellular component of this material, and it now just acts as a matrix to allow for cellular ingrowth. Studies that we've had over the years have shown that allografts do well when it comes to soft tissue augmentation. University of Michigan did a wonderful meta-analysis where they looked at connective tissue grafts and acellular dermal matrices, and they looked at all the studies on these topics, and they found that both autogenous tissue increased keratinized gingiva, increased gingival thickness, increased root coverage, acellular dermal matrices and connective tissue grafts. But ultimately, the connective tissue graft was still better than the allograft, which everyone kind of holds to be tried and true. I was fortunate a couple weeks ago to be able to speak at the Ramford Symposium at University of Michigan. And as you can see on the right, there's the Ohio State Buckeyes mascot Brutus. He was very disappointed in me that I actually went to Michigan to speak. But they offered me, Michigan has so much money. They just offered me so much money that I couldn't say no. I'm joking now. It was my honor to go. It was the Ramford Symposium for anyone who wants to get great CE, to see amazing lecturers. I highly recommend next year going to Ann Arbor to be a part of that. So when it comes to allografts, why do we use it in practice? Well, allografts do have a good aesthetic outcome, but mainly it's because there's no donor site. A lot of patients these days, because of social media, because of the internet, they're coming to our offices seeking alternatives to autogenous tissue. Even though sometimes we know it might not be the best option for the patient, it's something that they're seeking, and they'll go elsewhere unless you're able to offer an allograft for them. With allografts in my practice, where I think it really shines is I'm able to treat a large area at one time. I can do a full arch of soft tissue augmentation using an allograft, where if I was using autogenous tissue, it would take multiple surgeries. And because of that, you get less initial patient morbidity, which everyone today is looking for the easiest way, the least invasive way, where there's the least amount of morbidity. And patients are going to seek this out nowadays, again, because of what they see from their friends, social media, and the internet. So, typical traditional allograft site, we prepare the roots. We create a tunnel type recipient site, trying not to elevate any papilla, where we're able to coronally advance the tissue. There's our allograft. We slide it into the tunnel, coronally advance, in this case with sling sutures, and we let things heal. And again, traditionally allografts get a pretty decent result. We do have to coronally advance everything, so we do move the mucogingival junction coronally, which can sometimes affect aesthetics. But ultimately, when it comes to root coverage and tissue thickness, allografts do a pretty decent job. Again, do they do as well as an autogenous graft? They don't. But when we're treating an entire quadrant, like in this situation, really, when you have to harvest that much tissue from the palate, it was a very good trade-off, and the patient was extremely happy. But there's disadvantages, right? The disadvantage, one of the major disadvantages with allografts is you have to cover the graft completely. Where, if I'm going to be using a connective tissue graft to get root coverage, there's times I like to actually leave my connective tissue graft exposed so I can increase the amount of keratinized tissue that I gain. But with an allograft, because that allograft is devoid of cells, we have to cover it completely, or else anything that we leave exposed will ultimately necrose. But because that, we get limited gains in keratinized tissue, and we get coronal migration of the mucogingival junction. With allografts, anyone who uses a traditional allograft will know also, yes, there's a less initial patient morbidity, but sometimes these take a little bit longer to mature and to get a nice stable result. So ultimately, you have a little bit of a longer healing time. And then when we look at the long-term studies on connective tissue grafts versus allografts, at 10 years out, allografts just don't stay as stable when it comes to root coverage as traditional autogenous grafts do. But really, I would say the biggest disadvantage and why people fear using an allograft is the post-op complications or the possible post-op complications. Here's a case of mine where I was treating a full arch using a tunnel technique. Everything went well. Then the patient came back at 2 weeks and half the arch had a huge failure. And this case turned me off from using allografts for almost a year. This patient had horrible pain. The site was infected. As anyone who has used a traditional allograft knows, when these things get exposed, they smell, they taste bad. Patients just have an overall bad experience. And because of that, it actually emotionally hurt me. I was fearful to use an allograft again. But I got the courage to do it, and this is a typical result that I'll get with an allograft long term. And again, we do get good root coverage, we get good increases in tissue thickness, and again, ultimately the patients have a good post-op experience, which we're all trying to give our patients. So really, when I'm deciding between an autogenous graft and an allograft, I'm going to look at the patient preference. Look, some patients don't want to use an allograft at all. They don't like the idea of using cadaver tissue. Okay, I understand that. I have conversations with patients about, yes, we're going to not have to go to your palate, but maybe 10 years out, we're not going to see the results that we would see if we're using autogenous tissue. But to some patients, that does make sense to them. Technique sensitivity. As we all know, to coronally advance that tissue, to be able to create that tunnel can sometimes be a little bit more difficult. So there is, some technique sensitivity, which may make the procedure a little bit longer. But really, it's that risk of post-op complication, and that thought where I don't want this to happen. And I really believe that a lot of clinicians' avoidance of allografts is because they are fearful of this right here. But they're also sometimes fearful of this right here. This is one of my allograft cases where I did a full arch, and this patient came back to see me at 2 weeks. Everything in my mind was looking really good, but the patient was mad at me. Why was the patient mad at me? The patient was mad at me, says, look at this little white thing. It smells so bad. It smells awful. It tastes awful. It's dead to, and even though I did not have to go to the patient's palate, they were having a bad post-op experience just because of this small amount of exposure that happened. So knowing this, knowing that, okay, allograft tissue has to be covered completely. If any gets left exposed, it necroses, it smells, maybe there's not as much stability. What have we done over the last 25 years to try to improve it? When allograft tissue came out for soft tissue augmentation, that's what the MAC used to look like. It was that iMac. I remember seeing that when I was in college. Nothing has really changed in the last 25 years. Maybe we've gone, okay, instead of it coming dry, it comes wet, or there's antibiotics, there's no antibiotics. But really, nothing has been done to try to improve the healing of soft tissue allografts. So that's where the microsurfacing came in. So MicroDerm, it's a microsurfaced acellular dermal matrix. So you take an allograft, and you create these micro cuts in it, which increases the surface area of the material. When we look under scanning electron microscopy, this is what it looks. It almost looks like this layered puff pastry with these deep grooves in there, trying to increase surface area. And when we compare it to traditional acellular dermal matrix, you can see and this is the same magnification, you can see that there's a lot more space for cell infiltration to occur in the microsurfaced acellular dermal matrix versus the traditional acellular dermal matrix that we're all used to. But does this really equal better healing? Well, studies are ongoing, but the one study that's published right now is a medical study by Marinelli back last year, where they looked at, this is from the medical literature, where they looked at burns. And they took 20 patients with the same types of burns, and on 10 of the patients, they used traditional allografts. And on the other 10, they used microsurfaced allografts. And then they did biopsies of these areas, and they looked at these grafts between 12 and 19 days. So what did they find? Well, they found that in the microsurface grafts, you had greater cell concentration. You had greater cell infiltration into the microsurface grafts. You had greater thickness, which means that as time went on, as postoperative time went on, initially, between up to 12 to 19 days, you saw less shrinkage of the graft materials time went on, and you actually found more incorporation of the material into the existing tissue to begin with. What I found that was really interesting was that neutrophils were the predominant cell in the microsurface grafts. And what does that mean? To me, neutrophils are the predominant cell in natural wound healing. In the traditional allografts that they took, they found very, very, very few neutrophils. However, in the microsurface grafts, the neutrophils were almost the predominant cell, which to me made it sound like, that the microsurfaced allograft was mimicking natural healing. So with a microsurfaced acellular dermal matrix, with that increased surface area, we see increased cell infiltration, which could lead to increased vascularization, better incorporation, and better healing. And truly, this material basically sucks up anything that you put in there. Normally, when you have a dry, dehydrated allograft and you place it in any sort of fluid, be it saline, blood, it takes a while to absorb whatever liquid you're placing in. With microderm, basically any fluid that you place the microderm into, it absorbs readily within the first 30 seconds. So when people ask me, because I get a lot of questions now, because I've been speaking on microderm for a while. They ask me, so tell me about this new product. And I tell them, I say, it's not really, it's new. It's just an improvement. Think of implants. The original implants were smooth surface implants. We didn't change implants very much. We just roughened them. By roughening them, we increased the surface area, which equaled better healing. And really what's happened with microderm is we've taken traditional acellular dermal matrix and just increased surface area to increase healing. So what does that look like clinically? So here's one of the cases that I routinely show. And when I use microderm, typically I'm using these in vestibular access tunnel type procedures. So here I'm treating the canine in first bite, and you can see my vestibular access incision above the lateral. I could very, very, very quickly create a tunnel. Like this takes no more than 3 to 4 minutes to create this recipient site using a vestibular incision. There I am using a P. Charles periosteal elevator to make sure I have good coronal advancement. Here's my microderm. I typically trim it dry. It's very easy to trim dry. I flow it through the vestibular access, and you can see I don't hydrate it with saline first because I want blood to be the first thing that touches this material. And you can see how readily the microderm absorbs the blood. I coronally advance with sling sutures and set my patient off with some postoperative instructions and see them back at a couple weeks. And to me, the 2-week post-op, and I say this all the time, is really where microderm shines. Because when patients come back at 2 weeks, time and time again, this is what they look like. I'm going to show you long-term outcomes today. But the number one reason why I'm using this product more now is that this is a typical 2-week post-op, where the patient comes back with minimal swelling, minimal pain, and the tissue characteristics are excellent. Very, very little inflammation, and the patient's happy, I'm happy. And it's not like, in the past, other products didn't do well, but if you look on the left, these are cases where I treated with a traditional allograft, and those were my 2-week post-ops. Again, not awful. And to me, that's what I was used to seeing at about 2 weeks. And lo and behold, as time goes on, they heal just fine and this result. But really at 2 weeks, I was never seeing results like I'm seeing now with the Microsurfaced Acellular Dermal Matrix. So here we are, 2 weeks. This is what things look like at 6 weeks. I tend to leave my sutures in. I'm lazy. Here's 9 weeks. Here's 4 months. And now I get to come back and show 1 year results. And you can see after 1 year, we have good stability, good maintenance of tissue thickness. Again, it's hard for me to show the tissue thickness right here with this photo. Have we had a little bit of relapse on the first buy? We have, but the patient also had a pretty decent abrasion, abfraction lesion, whatever you want to call it. And I didn't do any odontoplasty in the area. So that may be why we did have a little shrinkage back. But ultimately, still an excellent response. And I'm very, very happy to see this. I would have been happy to see this with an autogenous graft as well. The patient was thrilled because the patient was treated somewhere else with an autogenous graft on the other side, and this is what they turned out with. So again, was this a good result from a periodontist standpoint? Sure. There was gains in keratinized tissue, there was gains in root coverage, but aesthetically, the patient was not very thrilled with the outcome and was super happy with my outcome where we didn't even have to go to their palate. So over the last 12 months, 18 months, typically I see these patients back at 14 days, 28 days, so 2 weeks, 4 weeks, 8 weeks, and then I see them up to about 12 months. So far, I have had no complete failures. I've probably done, 50 plus cases now. I don't know, but it's a lot. But no complete failures. Now, do I achieve 100% root coverage in every case? No. I'm not perfect, but every case has had at least 50% root coverage. I haven't had any cases with less than 50% root coverage, and currently it is my allograft of choice. So why is that? Well, I haven't had patients come back with any sort of smell, no signs of necrosis. I haven't had any infections. Patients are coming back saying they have less pain, less swelling, and I'm seeing faster healing. So again, with patients who are already seeking you out because they want a better postoperative experience because they've heard of issues with the palate, to me, this makes the most sense for them because they're going to have a better postoperative experience. Back in the day, I would tell people, it might smell a little bit. It might, that smell goes away after about 3 weeks, 4 weeks. Now I don't have to say that to patients anymore. They're not going to complain of bad breath. They're not going to complain of a bad taste in their mouth. So questions I get on social media, at the school, lectures, things like that. Is it stable? Have you seen stability? So I have. This is the first case I ever did. I treated a first molar. I treated a first molar because I said, who cares? It's a first molar. So here's a case where I treated a first molar. I did a simple pouch. I coronally advanced it. I may have done things a little bit different these days, but I wanted to keep it as simple as I could. And again, this was the first time I saw the 2-week post-op. And this is what it looked like at 2 weeks. So I was thrilled with this. This really piqued my interest. So again, let's say we're dating. I'm dating this Microsurfaced Acellular Dermal Matrix. I just found out that the dermal matrix is a Buckeye fan. I was kind of excited. Maybe we're going to go on a second date. So here's the 2 weeks. I was a little excited and, kept following the patient. And this is what the patient looked like at a year. And again, I was happy with this result. Have we had some relapse? We have. But if you look, we have good retention of tissue thickness. We have pretty decent root coverage. If you look at the gingival margins in comparison to the first and second premolars, they're kind of really at the same level. So we really were able to chronally advance everything and keep it where we need it to be. But again, I was really happy with the tissue thickness because you can see in the initial picture, we had no attached tissue, very, very little keratinized tissue, but really we didn't have anything resilient there that was going to resist further loss. So another case that I've been following, now this case I've been following very carefully because this is my wife. So I treated my wife with traditional allograft about 12 years ago on the left side. Here's the right side I'm treating. And why I say smell and taste, after I treated her, I treated a bunch of teeth on her. And, like 9 days after the procedure, we're sitting there, we're watching TV. I think we're watching The Bachelor. And she turns to me, she says, "Sean, my mouth smells like crap." I said, "Katie," I said, "No, of course, this is what happens. I tell patients all the time, it smells." So I'm sitting there watching The Bachelor, which I hate doing anyways. And all of a sudden, this finger just comes very sneakily under my nose. And she rubbed where it smelled, and she stuck it under my nose. And that smelled like the worst poop I've ever smelled in my life. It was awful. So yeah, now when patients come back and they say something smelled bad, if an allograft gets a little exposed and smelling, yeah, I believe them. It smells awful. Too bad my wife was the one, who had to tell me that. But, it smelled. But so for her, I wanted to use MicroDerm. I didn't want her to have the same experience. I didn't want her to, while I was sleeping, to stick her finger under my nose again. So here I was using a pouch technique. I'm basically creating a very, very conservative pouch, very easily able to tuck the MicroDerm into the pouch. Here it is sutured, chronally advanced. And again, here's 2 weeks. She had almost no pain. She used Advil for 1 day. She said it was much different than when we treated the other sites. Now, granted, I did more teeth the other time, but she was very happy, and I was very happy with the result. And here she is 1 year later. So when we compare the 2 week to the 1 year, yes, we have had a little bit of shrinkage. And to me, this was a very, very nice result. And honestly, if I had told you I did this procedure with her own tissue, you would have believed me. So to me, that's proof of a good result with this allograft. Now, can I tell you what this is going to look like in 10 years? No. But so far, she had a good post-op experience, and everything remains stable. Another case. So here we're treating canine and 2 premolars. Again, I'm using a vestibular access here to create my tunnel, insert my graft, chronally advanced everything. And here we are. This is 2 weeks. Again, the 2 week post-op is like the most magical thing with this material. We go on to 6 weeks. Actually, never mind, that's not 6 weeks, that's 1 year. So here we are 1 year later. So you can see pretty decent retention of root coverage. Have we had a little shrinkage back? We have, but again, I didn't do any odontoplasty. Perhaps if I had smoothed the roots out better, maybe we would have had a better result there. But again, patient was extremely happy. I was extremely happy with this result. Another year follow-up, doing the exact same technique, vestibular access, tunnel, place the graft, chronally advanced with sutures. Here I'm using glycolon. And here's the 2 weeks. So when we look at the 2 weeks and now we look at the 1 year out, you can see again, have we had some shrinkage back? We have, but a lot of that again is, I think, if you look at the abfraction abrasion lesions, really, I didn't smooth anything out. There's still a pretty decent concavity. And a lot of times with those patients, I tell them, I say, ultimately, maybe you'll need, a small class 5 restoration if you want to cosmetically make it perfect. But to me, we increased tissue thickness, we gained attached tissue, and we really, I think, did a nice job when it comes to root coverage when you look at the pre-op and the post-op after a year. So next question I get once in a while, what about the anterior, Sean? Can you use this in the anterior? You can. Now, I've used it more in the maxillary anterior than the mandibular anterior. So here's a case where I'm doing a a midline vestibular access, and tunneling to the right and to the left, placing my microderm, coronally advance everything. And here we are 2 weeks later. So again, at 2 weeks, really, really nice result. Here we are at the 4-week mark. Again, really good root coverage. Patient had a good post-op experience. This patient is actually off getting ortho right now, so I can't wait to get the final results after ortho's complete. So for anyone who's wondering, what the technique looks like in this situation, here's another anterior case. I like to try to hide my vestibular access incision kind of right into the frenum. So here I am making my vestibular access incision. I make a pretty long apical coronal access because I'm going to be introducing my graft through that access. So here I'm using a P. Charles periosteal elevator to tunnel and coronally advance everything. Continuing to tunnel, you can see the coronal advancement I'm able to achieve through vestibular access incision. And these are quick. Using a vestibular access to create your tunnel, you can do a full quad in like under 10 minutes. It really, really helps with time management. Here I am trimming my allograft, my microderm, taking a 2x4, cutting it into 2 1x4 pieces, using a very straight forceps to be able to introduce my allograft. And I make sure that when I'm introducing the allograft, everything's passive. I really don't want to try to shove it in there. When dry, the allograft actually is pretty easily inserted into the tunnel through a vestibular access incision. So here I am inserting it all the way, passively. And I like to show this photo because just by inserting the microderm, once it starts filling up with blood, once it starts absorbing blood, it actually gets a little bit sticky. And you can see I'm not doing any sort of active coronal advancement here, but just the material alone and the bulk of the material alone is coronally advancing the tissue for me. So here we are with everything sutured. I like to suture my graft and my flap together. I don't like to suture them independent from each other. And then I close up my vestibular access incision, typically just with chromic gut. So here we are, 2 weeks later. Patient was thrilled, had a little bruising and swelling of her lip, but she said minimal pain. And this patient sought me out because I told her that the best option she could have is her own tissue, but she just did not want to use her own tissue. So we did use an allograft. I told her, I said, listen, we're gonna migrate your mucogingival junction coronally. It might change aesthetics a little bit, but she was dead set on using an allograft. So when she came back at 2 weeks looking like this, she was thrilled. So here we are at 4 weeks, now at 8 weeks. And now as far as stability, I've only been seeing her, I did this 6 months ago, here's 6 months. So again, she's thrilled with this result. And now that I know that she's stable, she's now gonna pursue restorative treatment to give her the most ideal aesthetic result. So what about the mandibular anterior? I will tell you, normally I do not use an allograft in the mandibular anterior for root coverage procedures. Why is that? In my mind, that probably is the area that has the least amount of blood flow and least amount of blood supply. So anytime I've used an allograft in these areas in the past, typically it shrinks up a lot because there's not a great vasculature in that area. I just don't think you get the result that you get in other areas of the mouth. But here's a case where, again, this is pre-ortho. There were many teeth to treat. So I told the patient, I said, listen, if you want an allograft, I'll try the mandibular anteriors at the same time. So in this situation, I'm using 2 vestibular access incisions to create a tunnel that goes all the way from the mandibular right canine all the way back to the lower left first molar. Here you can see everything's been released, coronally advanced. Obviously, I'm getting imaging to make sure that I know where the mental foramen is. And then, same as before, 2 pieces of microderm. I like to cut notches on on the microderm now, when I'm inserting it, I find that it inserts it just because it's tapered a little bit. It sometimes is much easier to insert and is less likely to fold as you're inserting it. So that's my little notch I've been creating lately when I insert it. Here I'm inserting, and I always make sure the notch is facing apical, not to take away from any root coverage or any material that I want to add towards the gingival margin. So here we are inserting the microderm. And again, you can see here's where the microderm's inserted, going from the canine back to the first molar. And you see there's no sutures there. Just the material alone is creating coronal advancement of my flap. Here I am placing, after I've placed the other piece in the anterior, and then everything sutured with independent, each tooth having its own independent suture that engages both the flap and the graft. And here I was suturing with glycolon again. Here's what the patient looked like at 2 weeks. Again, patient came back, said, yeah, I had some swelling, but pain really wasn't that bad. Really, really good tissue response. And this is the furthest post-op I have, because I did this about, I don't know, 6 weeks ago. But this is what things look like at 4 weeks. So again, to be able to treat all these teeth at the same time, you could see we have good root coverage, good increase in tissue thickness. Now, again, this is only 4 weeks. In another couple of weeks, I'll have the 8-week result, and then I'll keep following this case. But I was really happy with this result, especially in the mandibular anterior, which to me is sometimes the biggest challenge for allografts. So other questions I get, well, what if it gets exposed? I have had people text me images and send me images of their cases where they had a pretty decent exposure. I have not had a blown out exposure yet. From the people that I talk to that have had big exposures, again, it gets exposed, but there's no smell, there's no infection, and the patient would know no different except for the fact that it looks white. From a case that I had a small exposure, this is what I found. So again, here's a case, I'm treating canine to first molar, sutured everything just like normal, but when the patient came back at 2 weeks, you can see I'm seeing some flap breakdown, and you can see the underlying microderm by the first molar. There it is right there. Normally, I would have freaked out, but this is after I've been using the material for a while. But normally I would have freaked out. I would have told the patient, I said, oh, I want you to take Paradex. I want you to dip a Q-tip every day. I want you to wipe it on there, and we're gonna go to our respective religious places and pray and make sure. But I said, you know what? You're doing great. I'll see you in another couple weeks. So this is 2 weeks. The patient comes back at 4 weeks, and it's granulating in. I was thrilled to see this. Patient comes back at 8 weeks, and this is what we see. So did I maybe not get the gains of root coverage on the first premolar that I could have if that didn't get exposed? Yeah, maybe, but the case wasn't ruined. I've had other cases where exposure of the allograft has really caused a significant limitation to my success. In this situation, everything was just fine. So is it just me? Am I, because sometimes I see people's lecture and I'm like, oh man, they're just so good. I am not that good. Like I'm lazy. I don't like to do fancy sutures. I don't like to suture things independently. I can't get vertical bone augmentation. I'm not one of those guys. I like predictability. So is it just me? Maybe it's just your hands. Let's use residents. Let's use Ohio State residents, because if a resident can do it, anyone can do it. These are good residents though. This is Dr. Taslim. She did this as a first-year resident. She's doing a very similar technique. She's making a vestibular access incision. There she is creating her tunnel. She did this whole thing by herself. Here she is inserting the microderm. Again, I love this photo. It just look how the microderm's coronally advancing everything without any sutures at all. Just the material alone is leading to coronal advancement, which is great. Everything sutured. At Ohio State, they like to take 1 week photos. So here's her 1 week photo. Look how nice the soft tissue looks. really not a lot of inflammation. Patient was very happy at 1 week, and here we are at 2 weeks. So again, even a resident can do this. This is Dr. Wu, John Wu. He takes the nicest photos I've ever seen, ever. And I will tell you this right now, this probably won't be the last photo of his out there that in CE world that you will see. So here's a case of a patient who had a previous connective tissue graft that failed and didn't like the contours. Really, there was really no gain in attached tissue. There's some root coverage issues. So and the patient didn't want to use their own tissue. So in this situation, he used MicroDerm, again, using a vestibular access, suturing. Here's the patient back at 1 week. Again, you can see how good the tissue looks. You can see how even the tissue looks now. I think this is 2 weeks out. Here's 4 weeks out, and I think he has a 4 month. And here's 4 months out. So again, you can see how the MicroDerm increased tissue thickness. Again, was able to achieve some root coverage. And again, this is a resident. It's and very good residents, but this is a resident case. So what's your technique? Okay, so I've kind of showed photos. I'm going to show you a video now of kind of how I do things. So here's a case where we treated 2 premolars and a first molar from 19 to 21. So you can see I've made my vestibular access incision, and you can see how quickly I'm able to introduce my periosteal elevator. I start apical to the mucogingival junction. I release the mucosa first, and then once all the mucosa is released, that's when I start moving coronally, because I'm less likely to tear the attached tissue if I have all the mucosa released. Here I'm opening up the MicroDerm. It comes dry. This is what it looks like. It kind of has, it's almost like a thick membrane consistency. Measuring out, you can see I'm very precise here. Should have been more precise, but I'm eyeballing it. Now I go to trim my MicroDerm. Here I'm trimming it dry with curved scissors. And there's no specific side to MicroDerm. Either side, it's not like there's a basement membrane side. There's no orientation of the MicroDerm. So here I've trimmed my MicroDerm, and just to show you how readily it absorbs fluids. Again, I don't like to soak it in saline because I want blood to be the first thing it soaks up. In cases where I soaked the MicroDerm in saline first and then introduced it into a flap, I really didn't get that red appearance. Now, does that make a difference? I don't know. But in my thought, I want blood to be the first thing that touches my MicroDerm. This is a case where I wasn't doing a vestibular access incision because I was a little fearful of the mental foramen. I didn't want to release so much that I was going to bugger the mental foramen, so I introduced it through a papilla instead. Still using my vestibular access incision to maneuver the MicroDerm, but I'm easily able to place the MicroDerm exactly where I wanted. I'm using a perio probe to get some final positioning, and then suturing with 5-O-glycolon, suturing both the flap and the MicroDerm together. I do not like suturing any of my grafts independent from each other. My thought is, why would I not want my the main blood supply to my graft to be connected to it? When they're swelling, the flap's going to move, and I want the graft to move with the flap. So here we are after suturing, and this is what it looks like at 8 weeks, and this is what it looks like at 1 year. So you can see great root coverage on the 2 premolars. The molar, did we achieve good stability on the root coverage? We didn't. Why? Maybe it was the crown margin. I don't know. But again, overall, I was still happy with this result, especially with the premolars. So next, what about implants? Another question I get asked. What about implants? Can you use microderm around implants? Well, I have. So here's a case where we had really good ridge dimensions, but we did have a concavity on the buccal, which would affect aesthetics, would affect cleansability. So at the time of implant placement, this is a case I normally would have maybe used a connective tissue graft to augment the soft tissue. But in this situation, I decided to use microderm. So here's my ridge, placed my implant, and then trimmed my microderm and placed it without suturing it. Again, when microderm touches blood, it absorbs it, and it kind of gets sticky. I was able to create a pouch and insert the microderm into the pouch onto the buccal of that implant. I didn't suture the microderm at all to stabilize it. Here it is. You can see it just absorbing all the blood. And I simply put 2 interrupted sutures, and I did this one stage with a healing abutment. Here's what the patient looked like at 2 weeks. Again, very similar result to what I've seen with root coverage procedures. Really, really nice tissue response. You can see the bulk on the buccal that's been achieved. So we said, okay, let's see what happens 3 months later when we're ready to restore. And that's what it looks like at the final check before I sent the patient back to restore. And you can see that we've eliminated the concavity, we have good soft tissue contours, and the patient is ready to go get restored. So this is a, let me throw whatever I've got at a case. This is a patient who came to me who had 2 ridge augmentations fail in the area, was wearing a partial, and said, I got to do something. I can't wear a partial anymore. And I said, well, I'll try to do the ridge augmentation and we'll see if I can get implants in. Again, I am not the Lord's greatest vertical ridge augmentator, we'll call it. But this was actually me post ridge augmentation. And we actually had bone. I was able to augment enough to be able to place 2 implants, but we still had a significant concavity on the buccal. So I placed the implants. We had good bone. I took a 1x4 piece of microderm, cut it in half, used 2 horizontal sutures, mattress sutures with chromic to create a sandwich here. And I placed the microderm on the buccal of the implants and just sutured with glycolon sutures. This patient was going to be getting pink porcelain regardless. I was just trying to improve the soft tissue contours. So here we are 2 weeks. Tissue's doing pretty well. You can see things are granulating in. And here we are at 8 weeks. So I was really happy with this result. The tissue looked good, but I was also thinking to myself, was it just the healing abutments that made it look like there was increased buccal thickness here? So I took the healing abutments out. And you can see the difference. I tried to take these at a similar angle to each other, these photos at a similar angle. But you can see the microderm really did a nice job of augmenting the buccal to get rid of that large concavity. So after that, I sent the patient off to get restored. So for any of you who are using it, my tips and tricks, again, trim dry. Don't worry about the side when it comes to microderm. I highly, highly recommend a tunnel approach. Again, I use a vestibular access incision. I think anyone who's not using a vestibular access incision, please try it. It makes life so much easier. You want to always insert the microderm dry, and just like any other allografts, leave minimal graft exposed. So in summary, this is another alternative that we have to the subepithelial connective tissue graft. Is it this amazing thing that's going to replace a connective tissue graft? No, it's just an alternative that we could offer to patients. It's got more surface area, which, in my hands, I've seen better clinical healing compared to other allografts. And I'm definitely looking forward to seeing more results and seeing results from studies to back up the clinical results that I have seen. So thank you. Russ, we should get to questions before people fall asleep.
Great. Yes, we have several. Appreciate it. Great stuff. And so I'll go ahead and get started with the questions. Some of these things, as you went through, you answered, but I think if they were asked, then they're probably worth even reiterating. So, first question to go with is, how do you treat the root surface if there's abrifications, root erosion prior to covering the roots with the graft?
I'm really nervous when it comes to taking a burr to a tooth. A lot of people aren't. I don't do any odontoplasty except just root plane the root with a curette, and I do put tetracycline on the roots. Not even though studies show that it doesn't do anything. I do it because my first graft in residency, I used tetracycline and it worked well, and I just haven't stopped. But I don't really do much root modification. But I do commend everyone who does root modification.
All right. Have you seen better color match with microderm versus traditional allografts?
That's a good question. In the long run, I don't think so. In the long run, I think if I look at some of the, if I look at 6-month results of traditional allograft and 6-month results of microderm, I think you wouldn't know much different, but definitely initially there's better tissue match because you don't see as much inflammation. That'd be a good study to do, but I've seen when it comes to microderm, it's that initial healing that really makes it for me. And and again, this is my opinion, but now that I'm seeing 1-year results, I used to find with traditional allograft at a year, it was a little unpredictable as far as the stability. Like I'd see, 6 months, everything looks great. And then a year, someone comes back and all the gains we got are now gone. I'm not seeing that as much. I'm not seeing that at all, actually, with microderm. I'm seeing, what they are at 6 months is what they are at 1 year. But again, that the most I have out right now is like 14 months.
Okay. Do you go full or split thickness whenever you're doing your tunnel?
Full thickness. Full thickness. Okay. Yeah, it's much easier to do full thickness. You get one's flat plane. The idea when it comes to bilaminar blood supply of doing a split thickness, I don't agree with. I think that you need to have a periosteum if you're doing a free gingival graft. But when it comes to anything where you're putting an overlying flap on top, I don't think you need periosteum on the bone. And it's much easier to do a flap when it's full thickness.
Do you remove any decay in the cervical area?
Anything that's soft, I'll remove. There's actually good studies to show that if you could remove decay and not put a restoration in there and still do a soft tissue graft. Anything that's soft or, I'll remove with a curette. But if it seems like it's really, really carious, I might refer back to the restorative doctor.
When do you remove the sutures that you're using?
I don't. I'm lazy. So I use Glycolon because they're there for around, in my hands, they're there typically about 3 weeks, which to me is perfect. I want something that's going to be there at least 2 weeks. A lot of people use PTFE sutures, and those are great, but they're sometimes a little bit of a pain to remove. The tissue sometimes likes them way too much, and you're digging for them. So I almost always use resorbable sutures that I don't end up removing.
Gotcha. Do you make a cervical incision as well as a tunnel incision?
Yeah, so I'll typically do most of it through the tunnel, through the vestibular access, and I'll go through the sulcus as well just to connect everything. So yeah, I'll always start with the vestibular. In these tunnels, I'll start with vestibular incision.
Okay. Has your post-op protocol that you discussed with your patient changed with the use of MicroDerm?
Yeah, I used to be a lot more careful in terms of what they're eating and brushing. I used to say, no, nothing on that side for the first 4 weeks. Now I say they can do something soft at 2 weeks. They can start brushing just the tooth at 2 weeks. No gum line at 2 weeks, and then they're brushing. I have them brush at 4 weeks with MicroDerm. So I think it because of the healing to me has been a little sped up a little bit. They're not having to be as careful for as long.
Have you used the material to cover exposed implant threads?
I have not. Yeah, those are tough, and I don't know. I still use autogenous tissue for that if we need to. Yeah.
Any issues with antibiotic allergies to the tissue from the processing?
So there's no I'm pretty sure there's not pretty sure there's no antibiotics on it. So that's not an issue.
All right, got time for a couple more. In a full arch implant case with a thin phenotype, would you be able to augment that to increase KT thickness?
That's a big question. Okay, so you can use look, anywhere you would have used an allograft in the past, if you use an allograft to augment thickness or on a full arch implant case, go ahead and use MicroDerm. Again, I think people say, well, where should you use it? I said, well, wherever you would have used allograft in the past. But I don't think you're going to get huge gains in keratinized tissue in KT, because no matter what, whenever you cover an allograft up, you're typically covering it up with mostly mucosa. So yeah, you'll get attached tissue, but you won't really get much in terms of gains in keratinized tissue. So I think I've not done it for a full arch implant case, but I would assume if you're getting good increases in tissue thickness using an allograft, you'll get the same thing with MicroDerm, but I don't think you're going to get any huge gains in keratinized tissue.
Okay, we'll do one more, and then there's a couple just friendly comments here. But you're showing some significant areas of large augmentation. We see some dieback that you mentioned in those large cases. Have you ever considered using Emdogain?
I have considered it. there's a lot of people who use Emdogain on all their grafts, allografts, autogenous tissue. I typically don't. Perhaps that would have improved it to get a better soft tissue attachment. One thing that I should start trying, because again, the MicroDerm readily absorbs whatever liquid you put in there, is trying growth factors with it. I think that would be, anyone who wants to try that, I think it makes sense to do that. But yeah, perhaps adding Emdogain would help, to prevent some of the dieback.
All right, and we'll wrap it up with that. I will, just because took the time to type it. What's up, Sean? Good lecture. Your old dental school classmate, Charles Clark.
Oh, what's up?
And then great presentation. Great presentation. Go Bucks is another one I got. So that is it. Dr. Rodenberg, really appreciate you taking the time to spend with us tonight. Once again, I appreciate everybody that was on the call taking the time to join us. We enjoy doing these webinars, and Dr. Rodenberg, you always do a great job. So thank you again.
Thanks for having me. Thanks, everyone.
I'd like to remind everybody before we log off here that you will get a feedback survey via your email. Please complete that, and that will trigger us to provide you with a CE certificate. And with that, I want to say good night. Hope everybody has a great evening and a good day tomorrow. Thank you.